Hello, my name is Peter Hunt. I'll be discussing mitigating risk and enhancing pediatric communications. In 2016, over 4.1 million child maltreatment reports were received by the United States Health and Human Services. Children under the age of 1, likely the most vulnerable group amongst an already vulnerable group, are 3 times as likely to die from neglect and abuse as those of any other minor age. Meanwhile, the American Cancer Society lists cancer as the second leading cause of death for children under 15 after accidents, and the rate of childhood obesity has more than tripled since the 1970s. These disconcerting statistics demonstrate the acute and chronic challenges facing healthcare providers. Combined with the special communication needs of pediatric care, the situation creates a compelling case for specific pediatric communication training for all general healthcare providers and organizations, especially as they relate to parents and guardians for these young patients. I hold a Bachelor of Science in History from the University of Nebraska at Omaha. My work experience includes 13 years of military service, including 3 years as an intelligence analyst and 9 years as an Air Force pilot. I currently serve as an Assistant Director of Operations, directly leading and managing 40 aviators in support of a 200-member unit and 24/7 operations. I'll be discussing a twofold framework of the problem. I'll make some training recommendations and also describe the precise framework of those recommendations. And then we'll look at some of the strengths and limitations as well as practical recommendations for the audience, followed by a conclusion. First, I'd like to discuss the problem of pediatric healthcare as a whole. In terms of economic costs, neglect and abuse alone in the United States brings a total economic cost of $124 billion annually. Meanwhile, overall healthcare expenditures for children were over $234 billion in 2013 alone. Of course, beyond the economic costs are personal costs. The Centers for Disease Control lists the top disease cause of childhood death between ages of 5 and 9, including causes such as heart and respiratory disease, septicemia, and of course accident, with similar concerns for other age groups amongst minors. All of these create the potential for both acute and chronic care requirements, as well as the need for diagnostic communication skills amongst providers. Further complicating treatment is the role of parents, guardians, and other family members in relation to the patient. In virtually all cases, a provider dealing with a child patient will find a complex human communication factor in a parent or guardian. In the worst case, a child's abuser may be a biological parent, legal guardian, financial provider, etc. for the minor patient. Though not always negative, parents provide a significant complication in therapeutic communication and may present as an asset to aid in treatment or as a hindrance in that treatment. In terms of patient competence and independence, infants are usually the most extreme case, as well as the most vulnerable. With that said, even in cases involving more communicative older children, the provider must mitigate barriers from parents in all areas, including unhealthy, uncooperative, or ineffective parental leadership, while also seeking to maximize therapeutic effects that family members can provide. The second element of the problem lies in the current educational efforts in pediatric communications. First, they tend to be limited in frequency, often provided an initial medical training, and that's it. There's also limited usage of virtualization as a cost and time mitigator that would allow for more frequent training events. Perhaps most importantly, there tends to be a reduced focus on parent-guardian as a gatekeeper or a barrier for therapeutic communications, as well as less attention paid to the risk and reward potential from parent-guardian input. Now we've discussed the problem, I'd like to talk about some of the training information and recommendations. The 2 key concepts for this training includes ensuring equal attention is paid to clinical and personal communicative elements, as well as focusing on the role of the parent-guardian as a gatekeeper for key diagnostic information. Depending on the parent, as well as the patient's health issue, the parent can range from helpful, inhibitive towards the child's flow of information, or hostile. While this presentation is tailored towards a general healthcare audience at the local level, the effective training focuses on the first-line provider, i.e. physicians and nurse engagement, usage, and mitigation of parent-guardian factors. Additionally, the training involves both initial and annual small group in-person events with quarterly virtual sessions via a similarly themed web interface program. The training activity itself is based loosely on a Cardiff University program for pre-specialization medical students with several key changes. Each training module or scenario is divided amongst 3 students with one facilitator leading discussion activities. In this method, there are no actors involved. Rather, each student will play either patient, parent guardian, or provider. As seen in these simple examples, each patient and parent are given cards with diagnostic information. For example, low T-cell count, circular rash, or high temperature, and will present them to the provider in a manner that rewards not only simple diagnostic skill, but also correct analysis of the limitations or benefits that the parent may be providing. For example, a patient with the parent in the room may present only a card that indicates bruising, whereas if that provider asks the parent to leave the room, they may receive a second card that indicates evidence of abuse via patient interview, or, in another example, they may receive more accurate sexual history from a teenage patient when their parent's not present. Each student will rotate roles and cases with facilitator-led discussion in between. Now that we've discussed how to deal with the problem, I'd like to talk about some of the strengths of the activity. Overall strength here, I think few would argue towards the clear need for effective pediatric healthcare and communications. These exercises, as in real life, require heavy emphasis on parents as a gatekeeper role to information, whether that's positive or not. As a weakness, there's potential lack of realism in using students and vice actors in all roles. With that said, this weakness may be offset by allowing students to experience different perspectives amongst the exercise players. Additionally, there's obvious limitations in dealing with infant patients. Designers of specific exercises should consider incorporating players in additional roles. For example, a spouse or family member to the primary parent. Finally, there's real potential for undermining legitimate parental rights in a real-world healthcare communication setting by encouraging driving the parent guardian away from the decision-making process for their child. Some practical recommendations. First of all, leadership and senior practitioners, their participation is going to be key in order to enhance the seriousness and the value of the training. Additionally, healthcare managers at all levels will need to ensure appropriate allocation of resource towards either programming or purchasing their virtual quarterly training, as well as hiring sufficiently qualified training facilitators. For example, another experienced provider. Finally, and perhaps most importantly, managers will need to maintain and update consistent focus on communication training throughout the provider's career, i.e., not just medical school, and not just an initial in-service. State licensing boards would also have the option of incorporating such training into their CE requirements. In conclusion, providers of pediatric healthcare in general find themselves faced with a number of challenges, with communication being only one. While many childhood diseases continue to affect the young population of this country, the parent guardian provides a real potential for both health and hindrance for providers. As such, an enhanced focus on almost game-like communication training as it relates to these parents and their associated patients, as well as continuous career-long follow-up training, allows providers and their organization to be better equipped to utilize parents when appropriate and avoid potentially undue influence when not. Healthcare for children is, perhaps, the most difficult for providers, as alluded to by the aforementioned preponderance of deaths in the 1-year-old and younger age group. The most vulnerable children in a health sense are also the most helpless in a communication sense. As such, focusing provider training towards parental interaction allows them to utilize parents as an ideal informational asset when possible, but also as a barrier to be mitigated when not.